There's a lot of good reasons to think that only well-resourced hospitals or organizations can afford to implement AI. And it comes down to, I would say, cost, talent, and scale. With ambient AI scribes, for the first time, burnout has become something that they've said, actually, this is really important to us. It reduces turnover and it helps improve satisfaction. So there is an ROI. Those solutions are, I think, really useful and kind of the gold standard for the type of way that we should have AI interact with humans, which is that we're still using the human judgment. We're using the AI to help overcome some of the constraints in the workflow. Yeah, I think we're there in terms of a lot of use cases being available to be solved right now. I think the frontier is pushing clinical reasoning, augmenting, and potentially replacing physicians for certain use cases.
Hey, welcome everybody to the DynaSpan Global podcast, where we look at myths surrounding aging and technologies, changing the way we live and grow up. Today, we're looking at some misconceptions we might have about hospitals and artificial intelligence. I mean, let's face it, at some point, we're all going to interact with hospitals and healthcare systems throughout our lives, whether it's for ourselves or someone we care about. And the hospital world, like everything else, is changing rapidly because of AI. But what does that actually mean? Is AI only something that major hospitals and enormous budgets are going to be able to afford? Will it make doctors better at diagnosing diseases? Will it give us more time with the doctors? Well, I mean, to help us separate the reality from the hype, I'm joined here by Arjun Gokhale, whose work focuses on the intersection of healthcare, data, artificial intelligence. Arjun, welcome to DynaSpan Global. And before we start breaking down some of these myths and misconceptions, why don't you take a few minutes and tell us about yourself and how you became involved in this field?
Thank you, Adam. Really excited for the conversation today. I ended up in healthcare at the intersection of AI through a lot of serendipity. Coming out of undergrad, I didn't have a sense of specifically what I wanted to do. I just knew I wanted to be in healthcare and ended up at a company called Epic, which makes one of the major medical records in the US. It showed me that while I was there, that physicians could play an interesting role in helping scale technology and make clinical decisions that help dictate the course of that technology so that it could be implemented with the patient in mind. I went to medical school, and there it was one of my first times seeing the big disparity in social determinants of health and the quality of care that people might receive based on kind of just the zip code that they were born into. And our university did a really good job showing us the disparities in care and making it really a moral imperative that we get involved. I trained in internal medicine, and while I was there, I really focused on trying to create tools for patients that had really low healthcare literacy to understand and take more agency in some of the decisions that were being made about their health when it came to key chronic conditions in a primary care clinic. I went to an informatics fellowship, and I was in the Bay. I was at Stanford, and an extremely well-resourced hospital. They had cutting-edge research that was pushing the frontier of what AI could do in healthcare, but then also they wanted to actually implement it in the clinic and at the hospital org. So I got to see how that worked. I think that combination of experience led me to want to work with AI in healthcare to see what we could do for patients and actually be able to create situations that were attractive to organizations to adopt that technology.
You are a medical doctor, but I want to tell everybody out there listening to this that, anything we talk about is not considered medical advice. And please don't use it that way. Even though Arjun is as a medical doctor, he's not advising anybody. Please consult with your own personal physicians if we come across anything that branches that topic. We're at DynaSpan Global. We're all about making sure that the patients and the people understand that these changes in technology are coming up. And that's why we created this series about myths, and so that there's not a lot of misunderstanding. It seems to me, based on your background, that you've seen it all firsthand, from the big schools to the small hospitals and being in front of the patient as a doctor, and now being on the backside and being in the actual technical side with Epic, and then now being on an administrative role. So I think it's going to be a great conversation. Thank you very much, so much for being here.
Yeah, absolutely. Really excited to talk about this. It's a topic near and dear to my heart.
All right, so let's jump into the 10 what we like to call the myths about AI and hospitals and healthcare. The first one is that people seem to think that AI and healthcare is only for major hospitals. So is it right for us to assume that only the big academic hospitals, rich with money and can benefit from AI? And as a patient, should we always be looking towards going that rather than to a smaller hospital?
Yeah. I think there's two really interesting components to that. There's a lot of good reasons to think that only well-resourced hospitals or organizations can afford to implement AI. And it comes down to, I would say, cost, talent, and scale. So some of these solutions are costly, just technology-wise. So the large EHRs, for example, really costly to, and not just purchase, but to maintain over time. You have to really build out a large IT org. And that becomes foundational, that system of record becomes foundational for implementing AI on top. Then there's the talent. So I think, it's harder in lower resourced areas based on salary, but also location to recruit top talent always. So that becomes difficult. The other, to take a baseball analogy, my first introduction to statistics was really through sports and baseball. And one of the books that was really formative for me was Moneyball, which talked about a low budget, like small market team being able to compete against these large market New York City teams. And one of the big points that they made was you can't make mistakes on big signings when you're a lower budget team. You have to hit every single decision that you make. And I think it's similar. So with the AI tools, you want to be at the forefront, but you also can't sign a big contract that might end up not producing ROI.
So a couple of things. EHR, you use the acronym EHR, just to clarify for the people out there, that's an electronic health record, right? It's basically a record of everything that's happened to you in any one hospital visit that you've gone to, correct? That's just to make sure that our listeners understand what these acronyms are. I always thought that AI would be more like a leveling tool, so that by the right AI, wouldn't that actually give that smaller hospital the tools so that it's more on par with the larger hospital, meaning that the patient might want to go there because the patient care might be better because of that?
Exactly. Yeah. And I think that's what's so exciting about AI is that the marginal cost of deploying the technology and having really high quality technology has been driven down significantly from some of these legacy technology tools. Now it's realistic if you're at a federally qualified health center, which in the US serves very underserved population where they might not have excess budget to pour into technology. They now might be able to pursue some of these AI solutions and reduce burnout and free up clinician time. So I think now if you're a federally qualified health center, you can afford chart abstraction technology to do quality reporting. You can afford a prior auth team that maybe is AI based rather than hiring out 3 or 4 FTE. So I think the ROI question becomes a lot more attractive, and it becomes tenable to invest in some of these solutions if you're
Keeping in mind what you said earlier, that make sure if you're going to investment, especially I suppose if you're a smaller hospital, that your decision has to be right on in terms of what the benefit, whether the hospital administrator has made the right decision. I guess it's okay for a patient to look at both a big hospital and a small hospital because the AI is going to be helping them both out.
I think so, yeah. And the switching cost for a lot of these technologies is low, and that also raises the bar for competition. When you're talking about a technology like an ambient AI scribe, for example, the adoption is fairly easy for clinicians. The training is fairly easy. The implementation, these companies have done an amazing job at making it easier to implement. So there's 80 plus scribes now on the market, and there's fierce competition. The products are improving every day. So I think what you're seeing is the cost is being driven down because of that, and the quality has really improved, and it becomes easy for an FQHC to now go after one of these solutions in a way that independently acquiring a medical record would be much more difficult.
Let's move on to the second one, which is AI in healthcare means better diagnosis. So, I mean, when people hear AI in healthcare, they usually think about diagnosing diseases, reading X-rays and bigger. But is bigger short-term opportunity actually reducing paperwork, or is it helping the doctors, and is it improving the actual diagnosis?
Yeah, I think it is all about where the constraint in the system is. And there are really good AI solutions that help radiologists triage and maybe even focus on this area of the CAT scan because there might be an aortic aneurysm here. Those solutions are gold standard for the type of way that we should have AI interact with humans, which is that we're still using the human judgment. We're using the AI to help overcome some of the constraints in the workflow. As a primary care doctor and generalist, I can say this, we're not always great about putting in the indication for the scan. And it's a common frustration of radiologists like this. So the AI can help pull in some information, save the radiologist that chart review time. So I think that's one. A lot of solutions that help with diagnosis, there's sort of, I would separate into administrative and into clinical. Doctors get excited about tools that help with synthesizing the chart and putting intelligence on top of that synthesis. So not just kind of data extraction, but something that aligns clinically with how you think and helps with a new insight. And most of the clinical tools have been more as reference tools that are AI-based, but still require the physician to put in the context of the patient and ask a question. I'm excited for this next phase where I do think diagnosis will become a tool, AI will be used to help augment diagnosis that is really more clinically relevant than relevant for administrative purposes.
So really what you're saying is that right now the AI, even though it is doing the diagnosis, it's really much more of an administrative effort than
much more.
So for the
That's
patient,
right. That's right.
It's still up to the doctor to tell them whether or not what they're actually looking at.
That's right. That's right. I think the way most of my peers have been using it in the literature to support this is these tools are really powerful, these clinical reference tools. They do still take time to use. So if you are pressed for time, you're in 15-minute back-to-back visits all day, you don't necessarily have time to come out of your workflow. But they're less helpful right now for in the visit, asking questions and coming up with a diagnosis. I do think that's going to change pretty rapidly because the advances these companies are making are really quick. And they're doing a great job with developing their tools. So I think we'll see that change.
One thing I will say is that our last guest, Pilar Anania, who we had on the podcast, and she worked a lot with medical imaging. She said one of the things that people are doing now because of this back-to-back is they're recording the doctor's visits, and they're bringing and they're feeding that into AI. So hopefully that'll work, and we've actually seen companies that do that kind of thing. So I think the technology is trying to help.
Yeah, I love that idea of patients coming in with recordings because it is so overwhelming when you're a patient to come in and remember what questions to ask, to absorb all the information. Sometimes we use technical jargon. Even if we aren't, it's a lot of information. So you want to be able to play it back, but then also be able to synthesize and ask questions and potentially even prepare for the next visit. So I really like that technology has empowered patients in that way.
All right. So the next one is buying AI really the hard part? I mean, is it more like hospitals don't have an AI problem? They often have like a change management problem. Is finding the right and buying the right AI tool actually the easy part, and just changing the workflow and inculcating it into the system, the challenge? And is that better in a bigger hospital or a small hospital for which patient to decide? I'm trying to figure out where the patient should go.
Oh, I see. Yeah. I think one of the big lessons in informatics is that the technology is a small part of it, but the people, the processes, the workflow are really the majority of trying to implement something. And I think where the AI tools have done a really good job is integrating seamlessly into those workflows. So some of these ambient AI scribes, they have had rapid adoption that we haven't seen with other technologies. When I was implementing the medical record, we had to drag physicians into it. The government had to create incentives for hospitals to be on it. These ambient AI scribes, they're being adopted extremely quickly. It's a click of a button for a physician. Even the implementation on the back end is pretty quick. It's seamlessly into their workflow. They just pull out their phone and press a button and they forget about it. And it integrates into the chart and synthesizes the visit. So I think for some of these AI tools, one of the upsides of the AI is that they are really thoughtful about how they're integrating into the workflows because they're solving new problems that couldn't be solved before. So I think rural or not rural, resourced or under-resourced, there's an upside to both. The AI has, I think these AI technologies have the benefit of helping these places stay independent and have sovereignty and governance over their own technology stack, which I think is critical for their own workflows. So if I'm a patient and I'm in a rural area, typically the paradigm has been, I want to go to a tertiary referral center for the best specialists, the best care, and maybe I don't have as much trust in my local institution, but I'm willing to go there if the time trade-off is worth it. But these tools, where they're rapidly headed, is the patient experience, the quality, that floor is raised through these tools, and I think it's going to make staying local a lot more attractive for patients.
That's the best side of AI in hospitals, is that it levels the playing field, like we said earlier. One of the myths is that doctors will simply use AI if it works. Maybe it was that way in the past, where there was a lot of resistance to adopting the AI, but now it is almost just like downloading an app for many of the applications that are directly related to doctor-patient care, right?
Yeah, the value of the tool has to outweigh the friction of the tool. So for the AI scribes, there's no friction and there's clear value from the clinician perspective. It's saving so much time with documenting, just making it freely available to clinicians, and they're seeing great adoption because the value of the tool is so high. It's like having a conversation with a subspecialist that I might not otherwise have access to, either on demand, or if I'm at a lower resource center, I might not have any access to a subspecialist. So being able to bring that expertise in-house and expand my own capabilities as a generalist really outweighs any kind of friction in pulling up, a separate window and stepping outside of my workflow.
It's amazing, because that's the hardest thing about introducing new technology, is working it into the workflow and the management of the systems. And if it's becoming more seamless now, that's a good thing for hospitals, and it's a good thing for ultimately for patients. So let's move on to I'm sure your favorite topic, electronic health records prepared hospitals for AI. So they were the beginning of it. Electronic health records were supposed to improve medicine, but it turned out many physicians say that they also created enormous administrative burdens and burnout. What lessons should AI developers learn from that experience?
Yeah, I think the biggest thing is that it's created a system of record. So now you can build on top of it. So if you have an agentic solution that calls patients and tries to close care gaps and improve screening rates, for example, you can use all that information that's in the EHR, that system of record, and you can just really build the solution and then write that back into the EHR and the system of record. So I think it's created a nice foundational base for these tools to build on top of without having to worry about. So if you're the AI scribe, you don't have to build the EHR. You can really just focus on your tool and making your tool the highest quality.
And all these new tools communicate with the EHR, and they just feed it in automatically?
They have to, I think, for adoption purposes, you really have to figure out a way to get it into the EHR. And this is true, I think, across industries, not just in healthcare. So if you had tooling built on top of a Salesforce or a HubSpot, you still need to get that information back in, because people aren't going to buy an enterprise license for one of these large tools and then try to document elsewhere outside of it.
So what us as patients should realize is that there's a central record with all our information on it, that wherever we go, there's a way to access our entire health history. So these EHR systems now are like holding all the personal health data of each individual, right? They're like a bank of all the important data that, and so if somebody goes to a hospital, they can say, oh, well, I had this problem, and then the hospital can find it, right?
That's right. And I would say it has all the important health system data. So if you have and in the US, there's increasing interest in this. If you have other types of data like wearables, things about your sleep score, that will likely still live outside the EHR, just because from a health system perspective, we don't necessarily know what to do with that data still. So if someone's telling you they're sleeping 6 hours a night, there's a future world in which integrating that data will be really important.
So the wearables now are actually talking with the EHR?
In some cases, especially for some of the use cases like remote patient monitoring, they are. Making sure that we're surfacing to the clinician just relevant information is critical, because otherwise you're spending your visit sort of reviewing a lot of information that isn't necessarily actionable and taking away from other priorities.
So how do we as patients know that you as a doctor are actually using the tools that are given to you, and that you're not just saying you are?
Yeah, I think frequently when the hospital is paying for the technology, they're closely tracking the adoption, so that we had great statistics on AI ambient scribe adoption when those come out, because they're really closely monitoring the kind of like the per user license or the enterprise license and making sure they're getting value out of it. I think for some of the wearables, that's a really interesting question. When there's a targeted question that the clinician has, they'll bring it up in their conversation. So a common use case is someone comes into the hospital, they lost consciousness, there's concern about an abnormal heart rhythm. And that abnormal heart rhythm isn't seen during the hospital stay with intensive monitoring, because sometimes it just appears sporadically. So we might send them home with one of a few different kinds of heart monitors. There's a targeted clinical question there. Did a specific type of heart rhythm, which might be really dangerous for this patient, did that occur during this monitoring window? Whereas something for sleep, there are targeted questions. Does this patient have sleep apnea? Is there some sleep disordered behavior that's occurring? In those targeted situations, we know kind of what to look for. So I think it's clinicians using the technology in a way that helps augment when there's a specific clinical question.
If you're wearing one of these wearables now and it's tracking your sleep pattern, then you don't need to go to a sleep lab, because that wearable is passing on the information. It's basically giving you everything that a sleep lab would give you, right? So it's actually saving the hospital money, it's saving the patient money.
Yeah, it depends on the capabilities of the wearable. So I think, like, for example, I have one that tracks my sleep, and there's certain information that you get on it, but it's not necessarily going to be able to diagnose me with sleep apnea. There are at-home monitors where they'll actually send you a kit at home to help monitor. So I think these are, but that's been around for a long time.
And I see you have that wearable ring there.
I had a long-standing principle that sometimes we overanalyze ourselves and we should have more bodily intuition. But, I ended up buying this about 6 months ago, and I found it very useful to help track my sleep and different habits that lead to me sleeping better or worse.
Then another one is that more technology in the hospital automatically means better care. So why do hospitals sometimes buy technology without patients or doctors feeling that the care is actually improved? So they have all this new technology, but the patients come out and say, wow, that was a terrible experience.
Yeah, I think in the US market, a lot of it comes down to administrative use cases and complying with regulations when it feels like a technology is adopted without improving the lives of the clinicians. And I think, a lot of doctors would point to EHRs as a great example. It's a big source of burnout. What we've seen with AI over the last few years has been it, even without having the clinicians necessarily have to see more patients to recoup the cost of the license, is that the marginal cost is so low. So you have these solutions that really are improving physician quality of life at a reasonable price.
Yeah. Well, I mean, anything to reduce burnout, right? And this ambient conversation thing is the way to actually be doing it.
Yeah, yeah. And I would say it's not anything to reduce burnout. Like historically, administrators and hospital systems have been happy to add a quality metric which increases documentation time, regardless of the validity of the quality metric. There's been so much research on medical documentation burnout, where it takes a clinician 2 hours for every hour of patient visit of documentation, and all these complaints have fallen on deaf ears for over a decade, and it's only now suddenly that reducing burnout is really important for us to do with technology, that it's become like a viable argument.
I think I want to have a conversation with a doctor over here to see how the EHRs were actually happening. Be an interesting comparison to look at. So,
Yeah,
go
yeah.
ahead.
Oh, one of the things a lot of my informatics mentors would talk about is in other cultures, like in Australia, when they're writing a note, there's really three purposes of medical documentation. There's the billing side, then there's liability, which in the US is big. So I need to make sure I document this, because if I don't document it didn't happen. And then there's clinical communication. So is what I'm saying going to make sense to another clinician? Can they understand my decision? And I would say it roughly operates in that order: billing, liability, clinical reasoning, and communication in the US. In other cultures, it's really that clinical communication is the most important thing, because there's less of a liability culture. The billing is kind of already built in and handled. So I would be really curious to hear what you learn. I wouldn't be surprised if it is a much different picture.
So one of the other ones is that healthcare data is already connected. And I know we talked a little bit about the EHR and being connected and walking into one hospital and walking into another. Personally, in the personal experience I had with my father going to the hospital, that was certainly not the case. So given the fact that EHRs are sometimes done on different systems, does that mean that there's a little bit of a bottleneck in actually transferring if I go from one hospital to another, useful way? And is that something that AI is going to facilitate as a patient in case I'm traveling and I need to go somewhere?
Yeah, I think at least in the US, this is something that continues to have to be solved by regulation, because incentives are such that it becomes tough to convince individual actors to actually want to share information. Healthcare is obviously different, because there's risk to the patient if we repeat scans or we repeat procedures. So we have to, for the public good of data, figure out a way to share. And I hope AI helps with it, but I think it's really more of an incentive problem. I think we've had the technology to do it. So hopefully maybe AI can help accelerate it. But the government, at least in the US, has made really strong strides towards improving sharing over the past decade, with some of the information blocking laws, some of the laws about making sure we have to release our information directly to patients. So I think it's a separate question from AI, but I see some positive signals.
Well, I think what a good advice that we can give people right now is that they should keep their own medication list, allergies, diagnosis, and key reports.
Definitely.
Don't assume that when you're going to a hospital or a doctor that they have access to anything. And I get it because it's data, right? Everything AI is built on is how much data it can access and how quickly it can analyze it. And health tech and health systems and working for individuals means that you have a special onus on you that other industries don't, because you're talking about people.
Yeah.
So I guess this is a good transition to one AI system. This is another myth, possibly, that one AI system will eventually, dominate healthcare. I mean, in technological history, we've often seen computers, systems, and standards coexist, like PC versus Mac, VHS, Blu-ray, Betamax. Do you see that there's a one type of system that's kind of taking control throughout the world?
I hope not, because I love where competition has taken us in the US market, where these tools, the quality has improved so rapidly and the cost has really decreased pretty rapidly as well. But I think you're right. Typically, these markets are winner take all, and we're seeing a lot of these companies raise at incredible valuations that it doesn't make sense just from a market perspective that at these valuations, all of these companies can win. I think my hope is there will be a handful of dominant players so that they're still forced to compete on quality and cost. The barriers to building are much lower for these tools. So I think there are some structural reasons why we will see multiple players in the market.
Well, I agree with you. I like competition. It drives for excellence, right? As long as
Mm-hmm.
we keep it fair.
Yeah, absolutely.
So, what about this one? The future of AI depends mainly on better algorithms. So, we already have enough AI to improve healthcare today if we implemented it better, or does the future mainly depend on better algorithms?
Yeah, I think we're there in terms of a lot of use cases being available to be solved right now. I think the frontier is pushing clinical reasoning, replacing, augmenting, and potentially replacing physicians for certain use cases. The tooling can do so much that's really immediately useful. Anything from chart summarization to triaging which patients to see. So there's real workflow constraints that can be solved today and augment capacity and capability. I think where pushing the frontier will be really useful is that clinical reasoning and helping augment and potentially replace sort of the more simple tasks in medicine.
Which is what AI is for, right? To reduce the burden of the administrative burden of everything, to allow the doctors
Yeah,
to do
yeah.
the job of actually interacting with the patients. I mean, now they're talking about televised or artificial doctors basically consulting with the patients. How do you feel about that?
I think if done appropriately, there are ways to make it really valuable. I think one example is in a lot of countries, you don't necessarily need a prescription to pick up certain basic first line medicines for common chronic conditions. And in the US, you do. So why not have an AI quickly do checks to make sure that it's safe? And that can help with a lot of, I think, chronic condition management. So that would be one clear area for me.
Um, so I do have a good question for you that I think you'll like because it kind of blends it all in. If you were the CEO of a 150 bed community hospital, what are the first three things you would do tomorrow to prepare your organization for AI, including what you might buy, and how would your patients notice the difference?
Ooh, I like that. The first three things in the US market, I I would probably break it down by use case. So administrative versus clinical. I would look at kind of like effort impact. So one of the things I would be really concerned about how do I prevent my physicians from leaving and reduce the turnover? Are there tools that can help with that? And then administratively, are there tools that can help me capture the value of what we're already doing? And then I would look at implementation. What's it take to implement these tools? I think an ambient scribe is a no brainer. You're improving retention at a place that it's hard to get people out there, and then you don't want them to leave once they're there. And then I think when you're a rural place, you have less resources to invest in some of the administrative requirements, like quality reporting that you are required to do. So that would probably be my next area. Look at where are things that we can augment areas where we have capacity issues. I think a really interesting example of the clinical side is bringing in specialists to areas that didn't have those specialists. And that's the type of thing that now as a hospital you could potentially insource, and that's a huge win for the patient. They no longer have to travel. And you can capture that billing as the hospital, and you also provide clinicians with a lot more satisfaction because now you're able to take care of the full journey of the patient. So I would probably also look for areas where you're winning in all those three dimensions as well.
Excellent. Well, I think that's a good place to end it. I want to thank you very much for taking your time and having this conversation with Arjun. I think it was very interesting.
Yeah, absolutely. This was a really fun discussion. Really enjoyed preparing for this and thinking through how this truly is different, I think, than other technologies, really because of the ability to extend the clinical capabilities in a way that other tools have focused more on regulatory and administrative compliance and use cases. So I'm really excited to see how this plays out at least the U.S. market over the next 5 years.
Well, I think it'll play out well in both markets. Well, I hope so. I mean, reducing administration costs, making the doctors, enjoy their patient visits more, reducing the stress. I think that'd be great for the patients and great for everybody else. Thanks again for being here, and for all the listeners out there. Thank you for joining us. Make sure to follow us and like us on LinkedIn, Instagram. You can check out our page at DynaSpanGlobal.com. And catch us for our next episode when we look at another 10 myths and talk to the experts and figure out whether they're real or not. Last thing to remember is that you're not getting older, you're just growing up. Have a great day.